All right. I think maybe we'll do a California start time, start a few minutes late. This is how we usually start our meetings at UCSF too. I could probably just start rolling though. Maybe people will trickle in, but either way, it's super great to be here. And just as a reminder, at 5 o'clock right after this, we're doing karaoke all night long. So just kidding. This is cool. We can walk around. All right. So my name is John Kleen. I'm from UCSF Medical Center, San Francisco. Everybody here from like California area? Anybody from out of state? Yeah. Out of state? Where are you guys from? Kansas City. Nice. My sister lives there.
Okay.
Champaign, Illinois. Wow, great. Anybody else? Alaska. Wow, incredible. This is awesome to have people just kind of come to Confluence here. Great. Well, yeah, I'm from Minnesota originally, and but I've been at UCSF for like 12 years, so quite a while. And can you guys hear me okay, by the way? Okay, sorry if I drone on or anything, just feel free to throw something at me. Okay, so today I'm going to talk about from computers to AI, how technology is changing EEG and epilepsy surgery. So we'll throw a little bit of history in there in the beginning. I hope you guys are okay with like just, I think it's just super fascinating to see like where we came from, to understand where we are and where we're going to go. And we're going to go a long way too. We've got a lot of work to do. I mean, people are still having seizures. Like a third of patients are not controlled with medications. It's just not right? And we actually haven't made much of a dent in that number for several decades. So, but we're hoping that, I'm personally hoping that technology is going to have a major role in closing that gap. So just real quick disclosures, I don't have any affiliations with companies. I just get funding from the NIH and NINDS, the NSF, just federal agencies. And another disclosure, I brought my daughter on the hyperspace mountain accidentally. I didn't even realize that it was oh, hey, Dr. Sullivan. I didn't even realize that it was actually a roller coaster. So I took them, that was like the first ride we went on. And this was 3 years ago, and ever since then, just no roller coasters. So we were at California Adventure a couple days ago, and just no days. She rode like a small one, but anyway, hopefully we'll. So just try not to take the kids too early on those. All right, so let's just dive a little bit into brainwaves, what they are, and the history of it. So this might sound a little bit kind of nuts, but there's literally the power of a light bulb in your head. Your brain is about 2% of your body weight, and it's about 20% of your body's energy usage. That's kind of nuts if you think about it. And the reason why is there's 86 billion neurons there, and that's a quadrillion computations per second. And computation, I just mean like one neuron fires and then talks to the other neuron. But there's so many of those, and there's so many of those communications happening all the time. And even that grain of sand right there is 100,000 neurons. So there's tons of energy being used, but in extremely small amounts. If you think about it, well, actually, it seems like a lot of energy, but it's so efficient, evolved over millions of years, that it's using about the same energy as a 20-watt light bulb, like the same kind that would go on when you like put your cup under to get some water, you open your fridge, that little light bulb in there. So despite using the same amount of energy, you're not a light bulb, right? We have thoughts, creativity, emotion, and when when these neurons communicate too much and they become very excitable, we get seizures, and that's a lot more electricity than a 20-watt light bulb. I don't even think that's been quantified yet, but just think of the capabilities of our brain. It's just incredible what we can do. But how do we even measure that? If there's 86 billion neurons, like how are we measuring these brain waves? They have to be kind of moving or firing in concert together for us to even hear them. Let me give an analogy to what that means here. So this is just a YouTube video I found of a stadium wave. Anybody ever been in one of these? Maybe even doing right now? Yeah, exactly. Joe started one, go across. There we go. Exactly. So, I mean, think of it, if all you were talking at the same time, all of us right here, I couldn't really make much sense of it, right? Especially if there were 90,000 people in a stadium talking at the same time. Just be noise. But if you coordinate them, if you have like the mascot run and say, okay, everybody go, now go, then it looks more like this, where you can literally see the pattern come out, right? You see that wave move across the entire stadium. And as other people see it, if they weren't involved the first time, they wait for it to come around. They're going to get involved the second time. So you get these rhythms. That thing keeps going around and around the stadium until somebody eventually stops it, and the camera person now is involved with it. But that's what our neurons are doing too. So they don't just fire randomly. They're interconnected, and they fire together, not all together at once, but they're connected in certain ways that they make these rhythms. And that's what EEG is essentially measuring. So this is from a really cool website. If anyone's ever seen this before, it does a really good job of like graphics, like comic style, and goes through what an EEG is and the history of it. But if you have one electrode on the back of the head, and you've got a couple thousand neurons firing together right underneath that electrode, if they're firing together, you're going to see a rhythm, as long as it's slow enough to measure, of course. And that's what results in brainwaves, and that's where EEG essentially came from. But I mean, who thought to do this, right? That's, we don't really think about that much. I didn't think about it that much, and then I was like, wait, where did this even come from? And so I did some digging in the past several years just to try to understand more about like where this technology comes from. And it was like a century ago, literally, like 1924 was the first time Hans Berger measured brain waves from the brain. And he tried for many years, trust me. They were doing this in animals. The heart, it was well known that the heartbeat was electrical. But measuring brain waves from the head was just sort of speculation. They had done it in some animal models and things, but he did all these special recordings, and eventually he needed someone to do them on. So of course he asked his son, and his son was sort of like the experiment at the time. He was just putting electrodes all over the different parts of the head. But just so happens that when he put it on the back of the head, what we call the occipital lobe back here, that's the area that processes mostly vision information. That's also the source of a very prominent wave called the alpha wave. And it was called alpha because it was the first one he found. Alpha is the first letter of the Greek alphabet, hence alphabet. But yeah, he recorded this in 1924, and he was still so skeptical about it, he didn't even publish it until 5 years later. He's like, I don't know if this is real, let me try a bunch more experiments. But it was real, and he showed it to a couple of close confidants, and eventually they realized it was the real thing. It was actually brainwaves coming from the head. And to do that, it required, I didn't even describe what this is. So this is the brainwave up here, literally the brainwave that was published that he measured. And this is just a sine wave to show like a 10 hertz sine wave. And you can see it's this beautiful rhythm coming from our brain. That lump of tissue in our head is generating this like gorgeous oscillation in the brainwaves when you put the electrode in the right spot, and also when the patient is doing the thing that would make it come around. So this wasn't during seizures, this was during eye closures. So if you close your eyes, you'll see brainwaves start to oscillate in pretty much all of our heads if we were to put an EEG on. I do this with medical students every fall. We teach like this course in neuromodulation. We have the EEG technologist graciously come in, and Mary Martinez is in the back. She's was working with us too. And they actually put EEG electrodes in the back, and we see the medical students can actually see their colleagues' brainwaves. So, but this is the machine that he was using. It's pretty massive if you think about it. So that's sort of what the theme of the talk is. This is technology like a century ago. Took a lot to get this to go, and it was literally like a pen that was like just hovering, and it was based on like positive, negative brain waves, and it would just kind of move like you ever see an earthquake, that little, it's the same idea. It's just a big roll of paper was constantly feeding paper past this thing, and it would be just noise, and then you'd see this rhythm when the person was doing something in particular. But that was just one spot in the head, right, in the occipital cortex. But to really understand the brain for clinical purposes, we need more electrodes. And this will be a theme of what I talk about the rest of this talk here. We need more data points to really understand what's happening in that brain of ours beneath the skull. We can't even measure it at this time. They weren't measuring it directly from the brain. So more channels were needed to record from different areas. And so Albert Grass is an engineer, clinician, and then Frederick Gibbs is a clinician as well. They worked together a lot to say, okay, how can we make like 2 or maybe even 3 channels together? And trust me, it sounds simple to me, but it was extraordinarily complex to do that all at the same time. But they were able to advance that technology. This is over at the Boston Hospitals at Harvard over there. And within years, literally, like this picked up so quickly because people are like, wow, there's something fascinating about this. And they started to record the first bursts of epileptiform activity, spikes. And they even started to capture seizures. I think it was absent seizures were the first captured because they can happen so frequently, and they result in a really prominent brainwave that happens in the EEG. So this led to, the NIH picked up on it. They're like, we have to make a huge EEG machine. So then people were like marketing it, like we've got the ability to do brainwave mapping here, and they did big articles about it. So that's the machine. I think they had several, maybe like over a dozen electrodes by that point. That was in the 1950s. And then you can see this little article that they did on that as well. But this is how EEG used to be, and I'm sure that some of you, maybe even some of you have had an EEG before, or certainly know people that have had EEGs, and they would literally have a person that was marking the EEG, the paper as it rolled past, and the point of that was if the patient coughed, it made a little squiggle. It was like, whoa, could that have been a little seizure, a burst or spike? But then they would say, oh no, the patient coughed. Or, oh, the patient's having a seizure, and would describe the seizure. Oh, turning their head now, like extending their arm. So that's how EEG was measured, actually up until like the 1980s and 90s. It was all on paper. So it just seems wild to me now because since I've been, here, actually I saw when I was a medical student back in the late 2000s, I saw this huge machine, and it, was actually a little bit smaller than that one, but it was still pretty large. And I was like, what is that thing? And my mentor at the time was like, oh, that's an EEG machine. That's a real EEG machine. I was like, okay, well, it seems pretty massive, because now we could literally record thousands of electrode channels on our phones, probably all of our phones. So let's just make a contrast again. 1924, one EEG channel. And then in the 1950s, they're like, okay, we have a couple dozen that we could do. And people were putting them all over in different areas of the head to try to say, okay, we recorded a seizure and it looks like a temporal lobe seizure. And so if you guys want to record a temporal lobe seizure, make sure you put the electrodes here. And they're like, well, we like to put them over here. So in 1957, they standardized it and said, we're going to come up with this thing called the 10-20 system. It's a standardized way to put the electrodes all over the head. And evenly spaced with these percentages. That's what the 10, it refers to 10%, 20% distance. So they standardized that in 1957, and luckily it's been the same ever since. So we can go off of the research that they were doing back in the 1950s now and all the way to today, because we know that the F7 electrode is right over here, that sort of thing. But still, that's a lot of paper. We worry about trees. We worry about the ability and the technical complexity of doing this with patients that need a lot more nuanced care, like where are the seizures coming from precisely, maybe even more electrodes. So in the 80s, people, actually even as early as the 70s, people were experimenting, okay, can we make this digital using computers? And I'm sure most of you probably know what digital is, so, but I like to talk about it because I still think it's fascinating, the concept of it. I mean, this is the paper EEG, and this is digital data. And what I mean by that is, as the brainwave is being recorded, the computer is coding it as ones and zeros in the computer, right? We've heard of like this, like the Matrix, they've got ones and zeros coming down. So the computer is laying down this data as ones and zeros based on where the voltage is at any given point. So these nice smooth waveforms that you see over here, it's actually a bunch of dots, right? It's made up of a bunch of dots. That's digital data. Digit just refers to 0 and 1, digital. So that's where we've been since the 90s, 2000s. It took a while for people to kind of take that up. You could imagine getting people to abandon their massive paper EEG machines and the reams of huge rolls of paper that they would have to go to digital technology was a big ask, but eventually people were like, okay, this is clearly much better, because instead of recording it in a certain way and saying, okay, we say reference every electrode to this one, we're gonna reference to this one instead. We can just do it on the fly. We can even add more electrodes, and that's what eventually came later. So this is just an EEG being done at UCSF. We still use this 10-20 system, but we actually add more electrodes commonly. And there's even certain centers that use like a cap for this. They'll do hundreds of electrodes sometimes. But this is all much more possible now because we have computers and we can just record it digitally. Imagine 100 traces of brainwaves just pouring onto a sheet of paper and then having to review 24 hours of data in the morning. They told me that they would roll the paper ream all the way down the hallway, and then they would just go look at it like this. Okay, it still blows my mind to this day that that's how they read. So, but why would we need more electrodes again? And I'm going to keep coming back on this. Well, I'm sure many of you probably know, some of you maybe don't, but the first medicine usually does the trick about 45% of the time in someone with newly diagnosed epilepsy. But if that one doesn't work, then we try another one. Maybe we'll add it or we'll try it instead. And that one will work another maybe 15, 20% of the time, which is smaller, right? And then the third medicine, it gets more to like 20, 25%, and it keeps dropping and dropping. So after the first 2 medicines, if the seizures are not controlled, it's time to understand if there's other options potentially available. Now, it doesn't mean that you'd want to move directly to something like epilepsy surgery. That's a big deal, right? Brain surgery is a huge deal. But every patient should know their options. And so after you're trying like the 3rd, 4th medicine, it's really important. Actually, I think the end of this last talk here really emphasizes it's important to go to a tertiary, like a level 4 epilepsy center, to get an opinion on, could there be other things that could help, such as neurostimulators or surgery. We do a lot of epilepsy surgery at our center. We get a lot of complex cases, and we love that because these are often people that have been suffering from seizures for years, sometimes decades. And epilepsy surgery is fortunately highly effective. It can be highly effective in most cases. So we won't dive into this data. I'll just say that this is looking at, on the x-axis here, it's 12 months or a year. And then there's 2 groups. This is a randomized controlled trial 25 years ago. It's like the gold standard in clinical care. clinical research. Some people were randomized to the surgery group if they had drug-resistant seizures, and the other folks were randomized to the continued medicine. So we'll keep trying medicines. And this is the proportion of patients that still had seizures over time. So you could see that the medication group drops pretty quickly, as we would expect. We talked about those numbers. But then if they underwent surgery and you measure after that, most of those patients remain seizure-free after. So it's a really, really good option for adults, and the same thing was replicated in children in a later study. I won't jump ahead to my little joke there, but it's really hard to find where to do the surgery, right? You have to actually really pinpoint where the seizures are coming from. A lot of what I'm talking about here is resective surgery. If there's one bad spot in the brain is just generating seizures and not doing you any good, the brain is usually moved function away from it, then maybe you could take that area out and you could potentially, we call it like functionally curing someone, like no more seizures is the goal. But to do that, you have to find where they come from. And scalp EEG is great. We talked about how we have many more data points, but it's still, in some ways, kind of like trying to understand what's wrong with your car by like listening to the hood and like, okay, let's listen over here. I think it's the problem's somewhere over here versus over there. We sometimes need to just kind of like open the hood, and similar to a mechanic, right? You take a look inside, measure directly from the brain itself to pinpoint the bad spot and especially the margins of what is bad. Think of tumor surgery in a way, right? It's very different in many ways, but it's similar in some ways. If you don't get all the tumor, there's a concern that it can come back. Seizures too. If you don't get all the seizure-generating tissue, the seizures could come back. So, did you have a question, Sam? Yeah, totally. Yeah, please.
You said twice today, I think, which is the seizure-generating tissues are not functional or they're bad. Do they lose their functionality, their whatever cascade involved with cognitive or emotional affective? Do they actually lose their functionality if they're seizing area, or do they function normally until the seizure happens and then they basically mess up the signal? What's exactly going on in that tissue?
Yeah, well,
So
there's two time scales to it. One is just, when the seizure itself happens. It's sort of whatever function should be happening in that area of tissue, in the area of the brain, it's not happening anymore because the seizure has absorbed those neurons out of what they're supposed to be doing into this seizure activity. And then when the seizure stops, that area is tired out, and it takes a while. Some patients it takes a minute. Some patients it takes days to come back to full function. But that's the short time scale of what seizures can do to that area. Now, over the longer time scale, months, but not really months, but more like years, our brains are plastic. And what that means is they can change and adapt over time. So if one side of my brain is generating seizures, I like to talk about the area called the hippocampus. It's a great memory area. It's important for memory function. And we have one on each side. If this hippocampus is generating seizures, let's say one a day or a couple a day, and it's also generating little bursts between seizures, we call these spikes of activity, then the brain is eventually going to be like, all right, we can't really rely on this area. Why don't we just move most of that function over to the other side? That hippocampus is doing fine. Other things can happen where the patient may notice that they're not able to do certain functions that well because they can't rely on it so much. So they might do certain things about their day differently. They might use lists, or they might use a different cognitive strategy. I hope people can hear me. So they might use a different cognitive strategy to compensate. And so that will sort of build up strength in other brain areas that are compensating for the area that's dysfunctional. We also have to be very careful, though, if it's right up next to areas that are doing stuff that's important. You can't just say, okay, let's take that whole area out. We don't need to worry. You don't want to cause dysfunction, especially in things like language, motor activity, things that are essential for our daily life. That's an awesome question. Really important, too. So we talk about intracranial EEG, and I'll talk about this most of the rest of the talk, but we do a lot of this at UCSF compared to other centers because we get a lot of refractory cases, like I mentioned. Refractory just means resistant to medications. And what I mean by intracranial is, so these patients, and again, many of you know this already, sorry if you know this already, but they'll come in a planned admission, and the surgeon, this is Dr. Chang, it's our epilepsy surgeon, he's an amazing epilepsy surgeon, the best I know. He'll carefully place electrodes in locations that we have all decided as a team weeks to months before that are the most likely areas that the seizures could be coming from. This is an example of what we call stereo EEG, which is depth electrodes only. and they go literally inside the brain tissue. They're very thin, so they really don't, they do very, very minimal damage, nothing that would cause damage itself, usually just a very low risk, at least like very low risk, like 1% per electrode. And then there's hybrid recordings, which is usually, this is what we do at UCSF as well. It's sort of a combination of depth electrodes and strips of electrodes over the surface, grids of electrodes over the surface. So there's no, they don't go into the tissue, they just get put on top. And in these situations, you can actually add a lot of those electrodes because they're not doing any damage. They're just going on top of the brain surface. So we can get a lot of really important detail. You know, we have the patient stay with us for several days, just like a scalp EEG admission. And then we wait for seizures. We'll reduce some medicines often to help make that happen. And then you can imagine, oh, if the electrode right here picks up on that seizure activity the first, that's the bad spot, but we also need to figure out if, like, what's the margin? How far does that bad spot get? And so you might already be noticing an issue though, right? That's a lot of electrodes you can see here. So one EEG electrode a century ago, now we're talking about 19 since the 50s in the scalp EEG. With intracranial EEG, it's often over 100 electrodes. And in these more recent electrode recordings that we're doing, high density recordings, they can be a lot longer. We're talking about hundreds of electrodes. So this is an example where we were putting the grid in anyway to try to understand where these seizures are coming from. And so we put additional electrodes between the electrodes that were already there. Again, no extra risk at all. It's just putting extra data points so that we can really get those fine margins. And I'll show you data that supports what I say there too. I'm not just saying like, you know, oh, it probably gives us better results. We really can figure out the margins even better. So another issue besides the sheer number of electrodes is where we put the electrodes. It differs from patient to patient. It's not like that 10-20 montage that I talked about before where it's always the same. Every patient has seizures that are potentially different. They're gonna have different curves and undulations. You see these curvatures of the gyri, we call them gyrus and sulcus and gyri and sulci. They may have had a lesion there, like we call it like sclerosis or a dysplasia, these sorts of things. They may have already had a surgery. So point is, every patient's different. And to understand those recordings, we have to look at each of these electrodes and cross-reference it with, okay, which brain did this even come from? We can't even tell, right? It's kind of ridiculous that there's so many electrodes, and we have to look back and forth so frequently to remember exactly where this bad signal here comes from in the brain. So as just a thought I had back as a trainee, like, oh gosh, it was almost a decade ago now, I was like, man, why can't we just make some software that takes that data and just puts it on the brain like a heat map? Just put it there in the original places where it was recorded. That would be so much easier. And it sounded so easy in my mind at the time. It was, of course, incredibly difficult to make it happen. But over a couple of years, I worked with the doctors as I finished training and became like an attending physician myself. And we were able to convert this into a technology. We call it OPSIA, which is, it's a long thing. It's omniplanar and surface casting of epileptiform activity. The short name is ictal cinema, so like movies of seizures. And I'll show you what I mean by that in a moment. I won't go too much into detail here, but basically we take the brain waves like this, and you can see one of the channels there, these 3 channels has a spike in it, and we convert that to this special thing, this special transformer, just a different way to look at the data, and we make it colorized. So the higher it is, the more pink it looks, and the lower it is, the more blue, or maybe it just, if it's completely normal, then it's just white completely. And then we take that and project it over the brain. We do this already anyway for every single patient, we get their actual brain and we plot it in digital space. We can rotate it, we can look at it at different angles. And so the idea of this is we just fuse the two, and then we can take a snapshot. This is just a moment in time where that seizure occurred. So I'll show you an example of what this technology looks like. And again, this is all done with intracranial EEG. But just want to give quick thought that there's some flashing during this, especially as we get towards the end when there's the clonic stage of the seizure. So if anyone has any sensitivity to light, then you might want to shield your eyes for, especially towards the end. But I'm going to try to make you all epileptologists now. I went through lots of school, way more than my parents anticipated. They're like, keep going to school, go to college, and then go after. And then I kept going and going, and they're like, when are you done? So, but after a PhD and MD, then you do the residency, then we did a year of epilepsy fellowship. But now we're going to skip all that, and you all are going to help me read the EEG. So where is the seizure starting? You can even just point to it. I'm sure you can see it, right? It's a hot spot right there. And you don't need to understand all, this is like what we're looking at usually as epileptologists. We're looking at all these brain waves passing here. And I sped this up a lot, by the way. This is an 8-minute seizure that I sped up to 1 minute. But you can literally just watch it play out like a video here, right? It is a video. We're just projecting that activity on the brain. this is where the seizure started. And this patient, was describing their aura. They were seeing some little bit of scintillating pattern in the upper right part of their vision. But now at this point, you can see it's spread beyond that over to this area of called Wernicke's area, where people understand language. So when I was in the room, I came in about this time, as a few minutes into it, and the patient was unable to respond to me anymore. He was responding before, but not anymore. And then the seizure continues to spread. It goes off the grid, literally, to these areas over here. And this area here is called Broca's area. It's important for producing speech. So then the patient became unable to talk. And then this is the clonic stage, or the tonic, and then the clonic stage of the seizure. And then now it's done. So that's an 8-minute seizure sped up to 1 minute. But you all could see where it came from, right? That's our biggest job. What we're trying to do is figure out where it starts. And we just saw it there. So we felt like that technology was really helpful, especially if we have grids and strips and different things on the surface of the brain. But a lot of centers, including our own, have moved more into putting more depth electrodes in. And because they sometimes come from the hippocampus or the amygdala or other deep areas of the brain. And so we needed to find a way to project the activity just like that, but on the deep locations too. So we came up with this technique called omniplanar views. Well, we didn't really, it's done by a bunch of companies, right? But I'm very pro open source, not company driven. And I was like, we need to make this into software that we can just put online and people can use. And so we were able to just track where each depth electrode goes. We took the arctangent back to geometry. Remember this stuff back in high school? I never thought I'd use that again, but we did. So we take the arctangent, we get that, basically a slice that goes exactly parallel to that depth. And we show the patient's own anatomy. This is their gray and white matter along that depth electrode there. There's another one right there. We show that gray and white matter there. So we have these omniplanar views in this patient with 5 depth electrodes, and we can project that activity in the same way on those deep locations. And so this is a different seizure. Again, there's a little bit of flashing later, but this is a different seizure, different patient. You can see that they have a grid over their right side of the hemisphere there. So this is where their nose would be. Sorry, I didn't orient you guys before. This is where the nose would be. The ear is like right here, so the brain is like right behind the ear here. And this is the back of the head. This is just the same hemisphere rotated. And this is the underside of that brain rotated to underneath. And then what I'm going to show you here is I show you underneath on all these views, but let's just watch a quick animation. It just flips over. So these are actually depth electrodes. That was just to show you where the cross section is, and you can see hopefully the electrodes there. Again, we're looking at this data usually as clinicians. We're reading this every day, but we can just, again, play the video and project it. And it's going to start in just a moment. Watch down here, the amygdala and hippocampal depth. You can hopefully see it spark right up there, right? The seizure started in the medial temporal lobe, the deep part of the temporal lobe, and now we can see it spread fairly quickly up to the side of the cortex there too. So keeps moving on. And then we can track these patterns, like really, as long as we have electrodes there, we can track what they're doing. We can't see areas where we don't have electrodes, but it's the same for this, the normal EEG. Like if you just don't have electrodes there, there's no way to know. But at least we can see the overall pattern. And that's what we're really trying to accomplish with this technology, is not have a bunch of squiggles that we all have to be going back and forth, but what's the pattern? If we see waves move over the surface of a lake, we can see that literally with our eyes, right? We should be able to do the same thing with this data that comes in 3-dimensional space of the brain. So as another example here, this can actually shed some light on really difficult cases as well. So this is a patient who had really terrible seizures for many years. I think it was like a decade or so. And we did scalp EEG, and we did this special technology called source localization, where we could try to pinpoint where the seizure activity was coming from. Yeah, it's like cell phone towers, right? If you have enough cell phone towers, your GPS or like satellites, you can figure out where you are on your phone, right? And if there's fewer cell phone towers, it's kind of spotty, it moves around. So we use these sensors and try to triangulate where it's coming from, but it's still outside the hood, right? We're still trying to recreate what's happening inside the brain itself. And so we got this. It's like for this patient, maybe the seizures are coming from down here, possibly here. It looks like there's another spot over here that could generate seizures too for this patient. So we're like, oh man, all right, we're going to put electrodes over those areas to get a lot more detail so that we can implant like a neuromodulation device, which are great too, right? They're fantastic, and they can reduce seizures overall, but they can't completely stop seizures, right? The only way to like functionally cure seizures is to do resection that we know of. But we thought she had 2 seizure onset zones. And then when we put the electrodes in here to understand where we were going to put her RNS electrodes, we saw a pattern. And this is, again, the same patient, but now this is her data. This is her during the seizure. And basically, you can hopefully see there's some bursts of activity over here, but also you'll see them suddenly propagate like this. So let's watch this a little bit. Let's rotate the brain around, and we can see this heat map just sort of smoldering away in this spot right here, right? There's also bursts that are propagating back across here. They're traveling quickly, but they're all coming from here. And if you don't believe me there, just keep watching. I'm going to rotate the brain a little bit more, and then I'll put a cross section where we had a depth electrode. And that same spot that is smoldering away, you can watch this activity sort of kick up the side here. It'll go right up that electrode, and that's what's propagating up to the frontal lobe, back to the back part of the parietal lobe. So this patient's seizures, even though they looked like there were multiple foci or multiple areas that they could come from, it really was just one hot spot. And that hot spot really wasn't doing her much of any good, so we removed that area. We did a right anterior temporal lobectomy, and she remains seizure-free now. It's been 6 years. She's still seizure-free. And that was just a QR code. Her story's online, too, if you want to read about her. But so we're very happy about those cases. We did an actual study of it, though, too, because we can't just make software and say, oh, yeah, this will fix everything. We need to do a clinical validation. So we checked to see if people could actually figure out where, like clinicians, if they could figure out where the seizures are coming from just from looking at the videos, not knowing anything else about the patient. And they did it with really solid accuracy. And you could even give a student, like a medical student, the same video, and they did it almost as well as a fully trained epileptologist. So we were very happy about that for clinical reasons, but also just for education, for when the whole team's together and we're making decisions with the surgeons, the radiologists, everyone in conference together, everyone can be on the same page. Like, okay, that's where it's coming from, that's where it's propagating. Okay, everybody gets it. Again, looking at stereo EEG with the depth electrodes, it can be a little cumbersome. You saw this video before where I had there's 5 different depths here. So we have 5 different plots for each of those. When we have 16 depths, it becomes pretty cumbersome. So this is a newer version we're working on called stereopsia. It's where we put each slice in the same brain and we just rotate it slowly. And this is sort of a work in progress, but it's just something I'm excited about. I just submitted a grant a month ago to hopefully fund this work to try to get it much better than this so that we can look at the propagation from depth to depth. This is the recording technique that most centers are using is stereo EEG, so we're trying to adapt this to where, again, all centers could use it. It's going to be open source, same as before. Open source just means free software. Yes, please.
Don't you have the ability to also do these slices inter-array electrodes as well, where you have, let's say you have the button two arrays coming in parallel to each other, but there are certainly some slices that goes in a direction where 3 of these or 4 of these array electrodes in each these 3 arrays also correspond to. At least as a line rather than a whole slice.
So when they cross or something, or when they?
So when they cross, like let's say you have 2 of these parallel arrays,
Yeah.
and then there are electrodes in each of them that also provide you a channel, a slice or a plane.
Right, plane, yeah.
Would you be able to then also match them with each other rather than just measure array by array, but across the?
Good point. Yeah, it's a good point. So could you use the activity from one depth to inform the other depth, or the slice from one slice to another slice? That's a great point. In a way, actually, yeah, so we do that in a way where when I make these slices, and I don't want to get too technical, but I'm glad you asked because I love this stuff. I'm a huge nerd, if you can't tell already. But each slice here, I generate the heat map using all the available electrodes. So if there's any other electrodes that are not in that depth, but they happen to be nearby, the seizure activity on those, if there is some, is going to reflect. It's going to show up on that plane too. So this way, I just put all the planes in there and I say, okay, those are the areas where I am sampling, meaning that we can actually have data from. And let's just project the activity based on what the recording is. And then all the areas where we don't have activity, they're just going to remain quiet. Actually, this is sort of I shouldn't even really be showing this area up here, the slices, because we're not recording from there. But I show it for context, just to understand where the anatomy is. But yeah, it's a great point that we have electrodes that come in completely different directions. And we don't want to just pretend like this depth should only light up this slice. It should really be what's happening in the global seizure. The entire seizures activity should be reflected on wherever we have data to show. Cool. So yeah, we've done this on over 250 seizures, over 120 patients, and counting. We call it like the EADDL Cinema Library. It's literally like a growing library of understanding many different types of seizures, different causes, different ways that they propagate. Some go very slowly. That when I showed you at the beginning was 8 minutes long. Others go rapidly fast. They'll be with in multiple areas of the brain within 100 milliseconds. But again, we can slow that all the way down to just super slow motion like you saw in another one. And then we published, this is our clinical validation study, and then again, the software is all open, and we're going to continue that trend as we make this software better and better for other centers. Another question that you may have is, I don't know, is anybody skeptical yet that more data is better, like more electrodes are better? Or does everyone believe me? Okay, good. I'm glad you believe me, because some, it's surprising that, some clinicians even, we're so used to just seeing a limited amount, and we're like, this is good. No, we can figure it out, right? But we could probably figure it out a lot better if we had more data. And sometimes when I show this with the higher density to other clinicians, they're like, yeah, okay, I can see what you're saying here. But let's talk about it in a different way. Let's talk about it as an analogy. Can anyone tell me what that's a picture of? It is a picture. How about now? Get a little bit more detail. You need, what's that? A person with a white shirt. Hey, we're getting somewhere. Can you tell anything else about it? Does anyone else want more pixels? We want more pixels, right? That means we want more data. We want more electrodes, is the analogy. So if we give more data, we can make a much more clear picture, right? We can understand what's happening, the overall pattern. It's a person that looks like they're giving a lecture. And we can even tell the margins a lot better of where in the picture the person stops and the audience begins. If we add even more data, it gets even more clear. So that's the idea here is, why don't we add more electrodes? If we're already putting electrodes in, why don't we put electrodes between those? There's not going to be extra, we call it morbidity or extra risk to the patient. If we're already going to be putting in a depth or a grid, let's add electrodes between the ones that are already on there. So we do this in many cases, actually. These are the electrodes that are available for us to read from, but only for research purposes usually, because these are implanted and we do some research. We try to advance language, memory, neuroscience at UCSF. But our clinical amplifiers actually can't handle that many channels because, again, clinical world is kind of slowly catching up to the idea of like more data is a lot more data is better. So this is usually what we're looking at on the screen. This is what it shows up as when we read EEG day to day, but this is what's actually available potentially there. And we don't typically record this. We only do it in like 5-minute segments when they're doing a memory task or a language task for research purposes, if they want to volunteer for research. But in our new monitoring unit setup, which just opened a couple of months ago, it was 7 years in the planning. We did construction all summer on it. Now we're recording from these 24/7, and we can capture seizures that happen on them. But we did happen to capture 10 seizures over 10 years during research. The patient happened to have a seizure during the memory task. And I did this heat map technology on those seizures on the full high density, and you can see like a lot of detail here, hopefully on that heat map. But I did the same thing with same seizure on the clinical version that we usually look at. And I hope you can see the difference between the two. You have to kind of look a little closely, but this is the most active electrode right there. But on the clinical version, we don't even have that electrode there. We don't even know that this area is the worst spot of that seizure at that moment. Over here, it looks like this whole seizure onset zone involves this entire segment. But here we're like, well, actually, maybe it's a little spotty, maybe over here, but definitely over here. So we'd probably interpret that a little bit differently depending on how many electrodes we have, right? That was my big worry, my big concern. And so I was like, let's do a study on this. Let's put them side by side, head to head, and have clinicians annotate, meaning like just trace the outline of where they think the seizure onset zone is in this version. And then I'll show them different patients, and then I'll show them the other version. They didn't even know it was the same seizure, actually. They didn't know it was the same patient, but they were just marking or annotating it. And we were able to show that, well, I'll tell you the results in a second, but I want to show a video of this, right? I've shown you like the screenshot, but let's just show the same seizure in the high density, which is on the right, and the low density, which is on the left. So I hope you agree that there's more detail. You're understanding the margins better at moment to moment, and you can understand, like, or at least I feel like I can understand the overall complexity in a lot more simplistic way with the high density. It just adds more detail there. So, yeah, please.
Is there a disadvantage in that having more electrode rays in to having too many. Is there anything such
Good
as
point.
treatment for the one
Yeah,
area?
there is if you're going to be putting more depth electrodes in. If it's, yeah, which we didn't look at here. So it's well known in the field, actually, it's been described. They look at the risk of each additional depth electrode. So when I say depth electrode, sorry, it's kind of a misnomer. It's a depth probe. Yeah, talking to the microphone. Each probe has 10 electrodes on it, or you could even do 5 electrodes on it. But you could also put electrodes between those, right? But for every probe you put in, there's an additional risk of bleed and infection and other small potential risks. But it's very small risk. We're talking like 1% per depth probe, but still, it adds up. You know, I've heard of some centers doing like 40 electrodes in one patient too, and that's, you know, it's increasing amount of risk there. Again, these are small bleeds we're talking about. The risk is small. We're not talking about very large bleeds. But again, this is different. I'm talking about like if you're already going to be putting a depth electrode in, let's add electrodes to that. Like a depth probe is already going to go in. Let's add more electrodes between the ones that are already there. So yeah, a really important point though, because if you're going to be putting more electrodes that actually penetrate into the tissue, it's got to be causing some small amount of damage, and it does have some level of risk to it. I do want to emphasize though that it's very small, and the ultimate benefit from this is a lot higher than the risk, and otherwise we would never do the surgery, right? That's why we have a whole team conference. Any level, I hope every level 4 epilepsy center have a big team conference. All of us epileptologists get together, pediatric and adult, neurosurgeons, radiologists, and we all make the decision together about whether to recommend surgery for the patient and what the surgery should be, where we're going to put the electrodes. We all do it as a team. So, but yeah, so this is an example patient here. This is actually the same seizure, so I could even have you guys annotate it, right? It's just software that they use to annotate it that we made. But this is using the high density recordings. So there's 6 different epileptologists. These are fully trained, board certified epileptologists. And this is what they annotated in different colors here for different epileptologists for the high density one. And this is what they annotated for the low density one. So I don't know. What do you guys think? Like, what are the differences here? Can you see it by eye? Detail? Yeah. Yep. Contours. Yeah. Yeah, please. Yeah. Right. So, well, the idea here is that, you know, well, I'll tell you the results of the study, but we did this on 10 seizures, 10 different patients, 10 different seizures. And it was basically very similar, like on each case. There was more detail that they would put the actual margins more detailed. They would also, so the main 2 takeaway points from that study was we were able to identify about 25% more tissue that looked like it could generate seizures when we use the high density. So that's already a really important thing, right? Again, I hate to use a tumor analogy because it's so different, but you don't want to leave tissue behind if it's going to be generating seizures. As long as it's safe to remove it, if it's generating seizures, we should remove it. And if we're identifying 25% more by adding electrodes, we should be adding electrodes to every patient this way, right? And so at least that's my thought. The other main thing that we found was that these 6 different scores, they don't always agree. You can see here, right? They're different. Their exact margins are different. But they tended to have more agreement when they use the higher density. So you want that situation. Anything that can help improve the consensus between people is likely a good thing. So that kind of hopefully gets at your question of how could this change surgical management? This did not change anything at the time. This is a study, a research study. But the idea here is that, okay, if we're identifying more tissue that's bad that needs to come out, and this is helping us all agree more that this is definitely the tissue we need to take out, then this could be hopefully sort of a game changer in the future for surgical management. And again, I applied for a grant last month to hopefully fund a study where we're going to do this sort of prospectively. We're going to see if having people score this and using high density and having that affect surgical decision-making results in better outcomes. That's the goal of it. I have a big hunch it will, but it has not been proven yet. So I'm not going to claim that yet, but I'm hoping. So did I answer your question? Okay, cool, great. So I don't want to go, veer off into too different of a thing, but I did talk about AI a little bit in the title, and the reason I talked about that is actually changing a lot of what we do now. We talked about going from paper EEG, right, from one channel all the way to like hundreds of channels, but then who reads all this data? That's so much data, right? So this kind of looks like a starfish. I hope people would agree with me there. This is from a study that was put out 2 years ago by a great lab over at Harvard, the Westover lab. Jin Jing was the first author there. What they did was what a lot of groups are trying to do, and they're the first ones to show it on just such a massive scale. They took scalp EEG data. This is scalp EEG. And they said, okay, we're going to take a 10-second snapshot, and we're just going to give it to this AI model. And then we're going to tell it that this is, a certain finding, like this is totally normal brainwaves, or this is a spike, or this is a seizure. So then they fed like literally thousands of scalp EEG full recordings from over 2,711 patients. And these are just 10-second examples, like 10-second examples of that. But the thing is, they took all these in that model, and this is called a low dimensional transformation. It just means they put it into this graph. And this EEG, that's where it fell in this graph. So this is totally normal brainwaves. Sorry, not totally normal. This is called low lateralized rhythmic delta activity. This is where it fell. This other one over here is seizure activity. It fell right here in this plot. This one's also seizure, even worse. It fell even farther out this starfish arm. This one over here, again, lateralized rhythmic delta activity, but even more prominent, so it fell over here. So hopefully you see where this is going. Instead of just having to rely completely on a clinician to look at these and say, oh, that's lateralized rhythmic delta activity, or that's seizure, you can just give this 10-second segment and it'll say, that's a seizure, or that's LERTA, or that's GERTA, or that's whatever else finding this is. The goal of this is to really understand, okay, if I take a small segment in the ICU of a patient that I think is really sick, if that data falls right here, I should be like, ooh, boy, I'm not an epileptologist, but man, that looks like it's a seizure according to this data. So they trained this thing called SparkNet, this AI model, to they trained it on all this data that was labeled, and they trained it on a bunch of unlabeled data, like meaning that data that people said was definitely seizure versus they didn't know what it was, and it either matched expert opinions or it exceeded that. So and it helped consistency as well. So that's where things are going with scalp EEG. It's really incredible in this day and age now. We can even, there's another study that came out the same year showing that you could just give a full routine EEG that you do in the office to a model, and it'll tell you, is it abnormal? If it's abnormal, it'll tell you which side, and it'll tell you in general like what the finding was. That's just the tip of the iceberg of where we're going. In 5 years, oh man, we might be able to read the full EEG with these models. So we did something like this in my lab, but we're more focused on intracranial EEG. And so and again, this is kind of closing out the talk here, and I'm sorry if I'm nerding out even more, but did the same sort of thing with intracranial EEG. Like I said, it's kind of like opening up the hood and getting more detail on the waveforms. And we fed snippets to this model, but it was a different question. We just wanted to know, is this a spike, like an epileptic spike, or not? But it's not a binary question. Sometimes it's like a little spike, or sometimes it's like normal, but like looks a little bit irritable. And so we did the same thing of plotting on this space, and this is what ours came out like. I think personally it looks more like a kiwi bird for ours. But the red dots here are the things that were abnormal. And so what we were worried might happen is that, okay, we give it to this model, and the red dots are going to be everywhere over here, and we're not going to be able to tell anything. But it was like the opposite. We have a gradient where everything, the farther it is to the right in this little pointed beak part, the worse it is, the more likely it is to be something that an epileptologist marked as abnormal. And then we applied this thing called a vision transformer. So this is a new AI model, and if you guys play around with AI, like ChatGPT or like Google especially, this is becoming the backbone of a lot of the most recent computer vision models that are available out there. It's called a vision transformer. I think we'd all agree this is a dog. So if you feed this picture into a vision transformer, it looks at the overall picture, but it looks at it in a way that we look at it. It doesn't just look pixel by pixel. It says, okay, it looks like these are eyes. It looks like these are ears, and these are snout. The position of the eyes and the ears and the snout in this array, in this way, looks like a dog. That's how it figures out 99.8 likely that it's a dog. So we did the same thing with our EEG waves. We just converted them from squiggles into heat maps. They're things called spectrograms. It's just a different way to show the data. We fed the same thing into the model, and we get this kicked back. It's a probability. So instead of saying, okay, well, is it abnormal or not? Well, we got to call the epileptologist. Gosh, we're out in rural areas. We don't have an epileptologist here, or we're in Africa. We don't have anything even like the capabilities here. We could just feed this to a model, and it could give us a probability like 92.7 likely that this is abnormal. So And again, we can put this into a probability. It gives us a heat map to tell us more likely to be ripples, which are normal findings, or more likely to be spikes, which are abnormal. So again, not to nerd out too much, but I just think that this is amazing. It's the way that we're going here. It's not where you just need somebody that's gone decades of schooling. It's where that person with a lot of schooling and fully trained has this at their side to help them figure out those decisions with the best possible accuracy. So the takeaway from today, EEG has been around for a century, over a century now, and game-changing developments have allowed us to understand seizures better than ever, especially moving from paper to computers and digital. But then after that, processing power innovations, more GPUs, different things like that, and then AI as well. We're just scratching the surface of what we can do with this. And also seeing is understanding, like understanding from visualizing the data. Hopefully you would all agree that you can really understand the seizures a lot better, where they come from and where they spread. And again, more data seems to be better. So thank you very much. Oh, please, yeah.
So one of the biggest challenges, as I understand, with epilepsy, I'm getting into epilepsy. I'm a neuroscientist, but
Oh, awesome.
understand we are developing a new method of brain imaging, and we are comparing ourselves to EEG in many ways. Temporally, very cool, but spatially, we have some advantages. In this case, what I understand with EEG is scalp EEG. In this case, not deep EEG. We are using with the scalp EEG is the localization, triangulation using other methods. You see San Diego has a great,
Oh, yeah.
EEG lab that they built for this kind of triangulation
Definitely.
and understanding where the location of each, where neuroactivity happens. In this case, for epilepsy, still many MUs are using scalp EEG, and therefore trying to localize that location of the seizures is still the biggest challenge. Do you know any AI improvement over this in the past 2-3 years since this whole adoption happened?
Yeah,
In
great.
terms of ability to localize better?
It's a great question. So there's a lot of people working on that exact question. Like, can we use the scalp EEG, but get the spatial precision, like where it's coming from the brain, as good as an intracranial study without having to do the surgery for an intracranial study? I could say a lot of people have thought about that and just like, oh, we got to do that study. But it's a really complex question because, and I don't know if have you heard of like the inverse problem? Yeah, so the inverse problem, just everybody knows, is like for any pattern of brainwaves that you see on the surface, there's like an infinite combination of possible sources that could create that pattern on the surface. So it's a problem because we don't know how to go the reverse, how to get that pattern and where it actually came from. But if you have electrodes inside the brain, especially if you have enough electrodes, you can potentially generate like where it's coming from. So how people are trying to answer that question is patients that get these intracranial studies, having them also get a scalp EEG at the same time. And then you would train your model basically on the scalp EEG data, but you know the ground truth, which is what's happening in the brain itself, under the hood, so to speak. So you need a lot of data for that. But as you saw, like every patient is different. So then we have a bit of what we call a sparsity problem. But that if you just have more and more data, you start to get around that more and more. So the goal to answer that question is really, you're not going to find, I think it'd be unlikely to see a single center be able to do that themselves unless they have, really we're talking like several hundred to thousands of recordings. But it's more likely going to be a multi-institution study that is going to all put their data together, standardized in the same way to answer that. We're collaborating with like University of Pennsylvania, NYU for a particular study where we're we've got like over 100 recordings, and they've got over 100 recordings each. So we're hoping to kind of get there to examine those sorts of questions. But I have a hunch that there's some groups that are farther than most with them, but I think it's still a ways away. I can't wait though, because it'll be amazing. Could you imagine if we could figure out with that detail without having to do the surgery itself? It'd be wonderful. Cool. Any other questions? Cool. Well, thank you for staying. I hope you enjoyed the movies and stuff. Okay. Thanks.